Good morning and welcome to Global Healthcast, brought to you by Global Healthcast. In this podcast series, once a week, we bring to you news and views about vaccines and vaccinations and infectious diseases. I'm Joe Schmitt, and with me is Dr. Melvin Sanicas. Good morning to Switzerland. Good morning, Melvin.
Good morning, Professor. Good morning, good afternoon, and good evening to those who are watching or listening to us today.
It is our first podcast this year. I apologize for being late. I had COVID during the Christmas season, so I'm back doing well again. So vaccination worked for me. I was not that sick, or I survived, and that is something at my age. What we talk about today is measles in Europe, early life digital experience and atypical sensory processing. We talk about long COVID and less energy in mitochondria. That could explain long COVID. COVID survivors and their risk for digestive diseases. The forgotten pandemic, it is AIDS. We talk about COVID-19 vaccines, what made them a success, the status of polio eradication, and the interference of enterovirus, rhinovirus, and influenza viruses. Melvin, you are the beginner and you speak about measles in Europe.
Yes, so this is the report from the WHO European region. They are experiencing an alarming rise in measles cases. Over 30,000 cases were reported by 40 of the region's member states between January and October last year. And this is compared to only 941 cases reported in 2022. So this is really a 30-fold increase in measles cases, with 21,000 hospitalizations and 5 measles-related deaths. And I think, again, the message here is that once the vaccination coverage is lower than 95%, you expect more cases, and with more cases, you expect more hospitalizations as well. And really, we cannot overemphasize that vaccination is the only way to protect children from this potentially dangerous disease. And people, especially parents, should think about this and really have their kids vaccinated.
Melvin, why do we see this increase? You have any clue?
Well, during the COVID pandemic lockdowns and restrictions, a lot of kids did not receive their vaccines. And also, of course, the usual vaccine hesitancy because of vaccine misinformation and all these different reasons, which are related to parents and children and parents mostly not really understanding the value of vaccines.
Yeah. So there is a good explanation for this, and we have to change this, right? So this is miserable. People dying from a vaccine-preventable disease. This is not acceptable. Melvin, you have a second very nice story for children that is really important, as I'm now a grandfather. This is really important for me. And what do you tell me with this one?
Yes, so this is not the first time we've featured something like this. We already had this last year, but this is another study. And the question is that, is early life digital media exposure associated with subsequent atypical sensory processing? And the answer is that yes. So early life television or video exposure was associated with atypical sensory processing in toddlers. So of course, this is not a cause and effect thing, right? We're not saying that this is really causing it, but what is worrying is that those toddlers or little kids who are exposed early in life to video or television, they apparently have higher chances of developmental disability, and that is, I guess, a message for the message for parents and caregivers is really limit the time for kids using tablets or laptops or anything that's digital media.
Yeah. Actually, I would believe there is a cause and effect. And, you can have a theory why that is the case. If you always look at something and if you don't like it, you swipe it away and go to the next and go to the next and go to the next. you have an attention deficit, right? You are like a butterfly flying from blossom to blossom and from flower to flower, but you don't look into the details. You don't stay with one item. So I think one could explain this, although the study type is certainly observational, so you cannot conclude on causality. I understand that. But for me, it makes a lot of sense. It makes a lot of sense. And we really can only urge people to not expose their children to too much electronic use.
Exactly.
Electronic devices. Yeah. Great, you found that. I'm very happy to hear about that. And that is additional argument for me and for my grandson. Melvin, long COVID, we discussed frequently in the past. And here you found something very interesting to explain why long COVID may exist.
Yes, so this is very interesting for me. This is from researchers from Amsterdam, and they have discovered that the persistent fatigue that patients with long COVID are basically feeling has a biological cause, namely that the mitochondria, or the powerhouse of the cell in muscle cells, this mitochondria produce energy, right? But in those people with long COVID, they are producing less energy as compared to that in healthy patients. And although this is a small number of participants, they only looked at 25 long COVID patients and 21 healthy controls. It's really very insightful, and it tells us that there is a big difference in the energy that's produced in the mitochondria of those who had long COVID versus those who have no long COVID. And I think this is a start for the medical and scientific community to have further research and potentially have a treatment or a cure for those who are feeling really weak and really tired because of long COVID.
So the energy in all of our cells comes from the mitochondria, where ATP is produced. And with long COVID, there is less ATP production. That is the story, right? Do I get that right?
Yeah, and it's one of the reasons, right? So you could see here in the cartoon below, and the illustration, long COVID could be caused by mitochondrial dysfunction, diet, maybe stress, inflammation, but definitely this really adds a strong insight into the picture.
Yeah. So here you're more careful with the interpretation. Again, it makes sense. And yeah, it's a start. It is a start, and that may, there is hope for some treatment. Yeah, very good. And I think, Melvin, that was the end of that story. And now we have COVID and digestive diseases. What's the story here?
Yes. So in this publication, basically, the researchers are saying that adult COVID-19 survivors are at a higher risk for digestive diseases, including gastrointestinal dysfunction, peptic ulcers, gastroesophageal reflux disease or GERD, gallbladder disease, and many other diseases that's related to the digestive system. And this is from researchers from the Southern Medical University in China. They looked at the UK Biobank database to compare rates of digestive diseases among COVID-19 survivors 30 or more days after infection in the UK. So this is really looking at patients in the UK. And the median follow-up was actually quite long. It's 8.4 months. And they observed that the patients who survive COVID, they have a higher risk for gastrointestinal diseases. And it was actually quite high, really, as compared to those who were healthy. So, for example, looking at peptic ulcers, it was 23% higher than the normal cohort. For example, for liver disease, it was 27%. For non-alcoholic liver disease, it was 30%. So really, if you compare this to those people who have not had COVID, it's actually quite high, the risk of getting digestive related diseases.
Interesting. So this is again an observational study based on the biobank. The interesting thing, it is the first time I see this, Chinese researchers studying data from from the UK data bank, quite funny.
Yeah, as I think you can access if you get
yeah,
permissions, right? You can
yeah.
access.
Very interesting. Yeah. And
And
then,
for me, the
yeah,
other interesting thing about this is they are saying that the reason, the theory that they have is that the increased risk may be fecal oral viral transmission interactions between the SARS-CoV-2 spike protein and the expression of the angiotensin converting enzyme 2 receptor, the ACE2 receptor in the digestive tract. So that's their theory for this.
yeah. Still, what strikes me is that all these diseases have so different pathogenesis and causes, from gallbladder disease to peptic ulcers, which is usually due to Helicobacter pylori. So my question would be, if this is something unspecific, I am not sure. But look, this is an observational study, and that is hypothesis generating, right? So now you can start looking into details, what the confounders may be, and but again, at the same time, the numbers are really, really high. The differences are really high. It is not a marginal finding, right?
Exactly.
Very interesting. So I had COVID at least twice now, and I don't have any GI disease.
That's good. Good to hear.
Yeah. All right. What I have is, there was the World AIDS Day in the recent weeks, and this is just a reminder that HIV claimed 40 million lives so far, and it is ongoing in many countries. Of roughly 40 million people living with AIDS by end of 2022, 2/3 are in the African region of WHO. In 2022, 630,000 people died from HIV-related causes, and 1.3 million people newly acquired HIV. There is still no cure for HIV, but there is effective medical care. The disease can now be controlled and managed. And AIDS, when I started in the late 1980s to treat AIDS patients, they all died within 2 years. And today, AIDS has become a manageable chronic disease, and you can live a quite normal and long life, and a quite healthy life if you are under appropriate medical treatment. Global strategies are to end the pandemic by 2030. So this is like 6 years to go. And by 2025, 95% of all people living with HIV should have a diagnosis, be taking life-saving treatment, and should achieve a suppressed viral load to reduce HIV transmission to others. So I think this is an important information and an important piece that I wanted to pass by to our audience here. Don't forget about AIDS. It is still ongoing and still an unsolved problem. Melvin, any insights and comments from you?
I think it's important that you emphasize, Professor, that although AIDS is a big problem still in the world, if you are HIV positive and you are getting your medication, you can live a normal life.
Yeah. So if you are worrying, get tested and make sure that you don't, number one, don't transmit the disease to others. And number two, you can lead a quite normal and healthy life if you take the appropriate medications. The next story that I found is vaccine development and the impact of the COVID vaccines on the COVID pandemic. And on this graph, you see vaccine development from identification to the microbe in the red points here, to first vaccine developed, and to green stars, that is 40% of the population are vaccinated. So you start out here in the 1930s with hepatitis B, and then you have influenza. And look, 40% has not been reached for influenza, right? Mumps not reached. Zika, there is not even a vaccine out there that is licensed. Varicella, you see, there are vaccines out there. There is a high vaccine uptake in some countries, but not globally. Then measles vaccine, that was quite good, but as you heard earlier today, we are not there yet. And I can go on with that, but if you look at COVID, the identification of the virus and vaccine development and the availability and 40% vaccine uptake was all within 1 year. And that was really unprecedented. And the story in this article by King et al. Is really not all vaccines are the same. So number one, there were 11 different technologies, and you see here, most people went for protein subunit vaccines, then totally new and never done before mRNA vaccines. That is really 40 vaccine candidates on that one. Viral vectors, DNA viruses, and so on and so forth. But mRNA was the newcomer, and they were the most successful, as I can show you in a minute. Now, 11 vaccines with 4 technologies only received WHO emerging use licensure. Only 11. And what you see here, and you see here the timelines, it was the mRNA vaccines, it was non-replicating virus, it was inactivated viral vaccines, and protein subunit vaccines. So this is quite interesting. Again, it is diverse technologies, and only out of these 120 something vaccine candidates and the few that really made it to licensure in the end, only 11 got emergency use license by WHO. And then if you look here, what worries people is where were the vaccines used? And they were largely used in high-income countries and less used in low-income countries. And the reason is certainly they couldn't afford it. Particularly initially, these vaccines were quite rare and we didn't have enough. So they came at a high price. What are the success factors for the 4 vaccines that really, or 5 vaccines that made an impact? Again, 32 products using a broad range of technologies received emergency use authorization by end 2021 by any licensing authority around the world, but only 5 really had an impact. That was the AstraZeneca, Pfizer-BioNTech, Sinovac, Moderna, and Sinopharm vaccines. And these 5 vaccines saved 17 million lives in the first year of vaccination campaign. Now, the critical success factors for an impact of these vaccines were prior experience with commercialization and approval of the producer, robust quality systems of the producer, rigorous process development strategies, flexible manufacturing facilities. If you have a factory that cannot produce an mRNA or whatever is needed, then your vaccine will have no impact, right? You cannot produce it. You need skilled workforce, collaboration with WHO licensing authorities, all types of companies that give you glass vials, syringes, whatever you need. You need access to consumables, reagents, and sometimes adjuvants. And finally, equitable distribution is certainly of real big importance if your goal is to save as many lives as possible around the globe. I thought this is a great article. I just highlight a few points, but I think this is really something you should read. It is a great piece. Any views from you, Melvin, on that one?
No, I think it really emphasized the fact that although there were many candidates in the beginning of the pandemic, I think at one point there were over 400 candidates from all over the world. And how many of them are being used at the moment? As you say, it's maybe 11, 15, if you count the other vaccines being used in countries like Cuba or Russia. Maybe there are like 15 or 16 vaccines being used, right? Out of the 400 plus in the beginning. Yeah. And so it's really showing us that it's not easy. Number one, not everyone will be successful. You have to have all these things that you mentioned, prior experience, robust quality systems, but also you have to be not late. You have to be able to join the crowd at the perfect time, at the right time. Otherwise, you will also not be able to be successful, even if you have all these things.
My Zetron Censeo here is what I always say, you have to be big and know what you're doing, and you have to have everything in place before the pandemic if you want to be successful. If you start today for a pandemic that started yesterday and you don't have the resources, you will not be successful. You have to know what you're doing, and you have to collaborate with marketing, with commercial, with in intellectual property and all of that. It's a huge requirement, and this is why only big pharma companies were successful in the end. I'm not sure, correct me if I'm wrong, but there was no startup that was successful, although they had very good ideas. And BioNTech was a startup, but they aligned for good reasons with Pfizer.
Exactly.
So that was the success factor, right? And there was another German biotech company that had an mRNA vaccine, and they were not successful. And they didn't, work together, collaborate with big pharma. So anyway, this is a great paper. Read it. Now I have a story on polio. And if we look at the polio situation around the globe, wild polio virus 1 is still circulating in Afghanistan and in Pakistan. Now, if you look then to other countries, there is no more wild polio virus at all. Very, very good. So only 2 countries in the world by today have wild polio virus, and that is always type 1. Type 2 and 3 are gone. If you look to African countries here, you will find that there's a circulating vaccine-derived poliovirus 2. So the oral poliovirus that we use to fight polio, to eradicate polio, this reverts in not appropriately vaccinated populations and becomes a wild virus again, or a neurovirulent virus, a virus that can cause disease. So this is now here a vaccine-derived poliovirus type 2 that is circulating in Chad, in Côte d'Ivoire, in Nigeria, in Sudan, and in Zimbabwe, in 5 countries. So what needs to be done is you need to vaccinate more. You need to make sure there are no more susceptible people out there. And for that, again, you need oral polio vaccine, because mass vaccination in these countries with an injectable vaccine probably wouldn't work. There are only 2 countries with CVDPV1, and that is Democratic Republic of Congo and Mozambique. But again, what you can see in 6 African countries, there is CVDPV2 circulating. So this is the big problem. And this is just the summary for the beginning of the year. Maybe we look at this again by the end of the year. What will be the policy to fight CVDPV2? Any insights, reviews from you, Melvin?
Well, so my very naive suggestion several years ago was really to have everyone vaccinated in a short period of time. Like, for example, 3 months, right? Make sure that everyone is vaccinated within a span of 3 months so that the virus doesn't have anyone to infect. But I think that is not possible.
Yeah.
For so many reasons.
Looks very, I guess others have had that idea. And I remember like 20 years ago, when we discussed polio eradication, the one article or one presentation I heard, it was, the headline was "The Art of Ending." How do you end vaccination? You want to end vaccination because of this circulating vaccine-derived poliovirus 2, but you cannot, right? So how do you finish up with this? And this is a big problem. Again, vaccinating everybody in Africa and in Afghanistan, Pakistan over a 3-month period should solve the problem. But I'm not sure. It seems not to be feasible, right?
There are other reasons. For example, there are rebels, there are insurgencies, and all these things that are not health related. So
it is political. Yeah, it is political reasons. Yeah. Anyway, I have one last very interesting story. What you see here is over time from 2015 to 2019, the circulation of influenza virus in blue and enterovirus rhinovirus, which is Picorna viruses in the end at the same time. What you see here is if influenza is high, Picorna is low. And then high and low, high and low, high, or it's about the same, high and low, high, low, high, low, high, low. So these authors looked into this a little bit in more detail. And I just tell you the summary. There is epidemiological surveillance, and the sequential infection in vitro suggests viral interference between enterovirus rhinovirus or Picorna viruses and influenza virus. Operates at the population, individual and at cellular levels. I would have started with the cellular levels. That is the basis. Something happens in a molecular basis, and then that has impact on co-infection on an individual and also then on the population. Very, very interesting. We found similar things 20 years ago when we were first developing multiplex PCR in 1995, and we were running studies with it. We found very interesting interactions, and this is just confirmation that this was real data that we found at the time. Any comments from your side, Melvin?
So I think this reminds me of other viruses as well, Professor, like talking about dengue, for example, or other flaviviruses, and looking at, let's say, Japanese encephalitis in places where this is huge. You don't see a lot of dengue, so maybe there's something there as well.
Yeah. The interesting thing is our studies with multiplex PCR and epidemiology and respiratory viruses was stopped funding by the German government by saying infectious diseases no longer play a role. And that was in 2007. And then I decided to leave academia and to go to industry. And I think it was a good decision because infectious diseases never were conquered, right? They continue. And I think it was a stupid idea that they don't play a role at all. But what can you do, right? Melvin, this was a fun discussion today. Very nice topics we discussed. Measles in Europe, high again, maybe due to COVID and reduced vaccine uptake. Early in life, don't use electronic toys too much. Control the use as little as possible. Long COVID may result from less energy in mitochondria. COVID survivors have a higher risk for digestive diseases, data from a UK data bank. I talked about the forgotten pandemic, HIV and AIDS, and that there is the goal by 2030 to have it all under control. I told you about COVID-19 success factors, what you need in place to have an impact with vaccines and vaccination. We spoke about polio eradication on the globe and the interference of picornaviruses and influenza viruses. With that, I finally have a cartoon. And here it usually, Pavlov's dog, but on a website on cats, it is certainly Pavlov's cat. And here the cat is ringing the bell and the owner of the cat starts and serving the cat with food. The message is control yourself and don't be controlled by others. Use your own mind. Look at data like what we present here and make up your own mind and opinion and don't follow the bell of someone else. Melvin, any last views and comments?
No, I think it's just funny because you can interpret this one as like, is the cat controlling the man or the man controlling the cat?
Yeah, here it's the cat, right? It's a reflex. So very good. With that, we finish our Global Healthcast 56. Thank you, everybody, for joining. If you liked our podcast today, please like and share us. And I am Joe Schmitt, and goodbye until next week.
Thank you, everyone. Stay safe.